unluckily, that my working place right now is not a pure teaching hospital. It's like more of private practice. But I get some chance to teach and learn from others. So the learning process is a steep curve. It's not a curve that you reach and you stop for the rest of your life. Okay. So thank you again for your invitation. And I'm very ready to start my presentation when you are ready.
Okay. Yeah,
And
I'll
one
let you
more
know.
thing.
I'll let you know, Doc. Okay, I'm just setting it up there. Right now, I'm putting it on YouTube. You know,
All
this
right.
also goes on YouTube, right?
Yes. I will take the link after that to share it on my social media platform. I have some like social media page and
Yeah, if you share
like
the link of
Facebook.
what I sent you, yeah,
Sure, I will
it's
do
just
that.
yeah, please,
So,
because the more
and
people know, the more choice they have if they're
sure,
interested in what we're doing
sure.
today. Okay, let
So
me.
thank you again. Mhm.
Yeah, no, if you yeah, I know now that
Can I?
you like to broadcast, right? You like
Correct.
that. Okay,
Correct.
that's great. That's great for Ahmed to know that, and for me to know that, because sometimes we really
Sure.
need speakers. Okay, let's start,
Sure.
gentlemen. Okay, let's
All
start.
right.
10.
Mhm.
Oh, excuse me, Ahmed. Do you want to introduce Dr. Musin?
Yes.
Oh, you're gonna do it, Abdel? Okay.
Okay.
Abdurrahman.
Yes. Okay.
Is that okay, Ahmed?
Okay.
Abdurrahman will introduce him.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. Actually, good afternoon in Miami Beach, home of Neurosurgical TV. We have another webcast from the Yemen, very active Yemen neurosurgery community. And let me introduce the chairman of this, Abdel Alatir. It's all yours to introduce the speaker. Thank you.
ال- Wilter Tandy, hand neurosurgical TV. Her introducing one of the best neurosurgeon in the world, Dr. Baha'Elddin Mohsen, member of FENS and MRCSI. Uh, 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 he has a Jordanian board of neurosurgery. We'll talk about skull-based tumors in the context of evolution and radiosurgery.
Okay.
Okay.
Okay. Thank you.
Doctor, it's yours.
It's all yours, Doc.
Dr. Baha, can you hear me?
Yes. Okay. I guess did he fall off? I don't know. He may have fallen off. I wasn't watching there. Yeah, he'll be back. I guarantee it. I've never seen a speaker not come back because they're usually prepared for this. And like most people, they don't want to waste their time. He's back. Okay, doctor, it's all yours.
Me?
It's yours, Doctor. You
Hello.
can go ahead.
Okay.
Can you hear me, Doctor?
You put it on big screen, on presentation mode. Can you do that? Ahmed, can you explain?
Dr. Baha, can you hear me?
Yes.
I hear you. Yes. Do you hear?
Amazing, amazing. We have introduced Your Excellency,
Yep.
so you
Let
can
me
go ahead
just.
if you want.
Yep.
Could you
Yes, I
explain,
hear
Ahmed,
you.
how to put it on big
Is
screen,
that
please?
clear?
Yeah, it's
All right.
better to have it as full screen.
All right. And let me just open the. Is that clear now already?
It's not the right size. It's
Yep.
got to
I
be
think I'm in
big,
full screen now.
big.
Like
No,
it's
not now. No,
in
you're
full
not.
screen to me, isn't it?
You can just click on play. Yeah, yeah,
Oh,
that's it.
perfect. Okay, perfect.
أنا كبست على play.
Yes,
Is that
please.
ready?
Yes.
Perfect. So again, thank you, John, for this
Doctor, I think there is a problem with your voice and there is interruption.
international webinar and from the World Society. My name is
Doctor, can you hear me?
surgery. I have some experience alongside a general neurologist. I have.
Hello?
Is that you hear me? Is that
Yeah, but there is interruption
Esther?
with your voice, sir.
I think me. Do you hear me? Hello?
Now it's better.
I hear you.
Yes,
Oh,
we
amazing.
hear
But
you.
there was interruption with
I
your voice. But
hear
go
you
ahead.
very well. You hear me?
Yes.
Now it's better.
Oh. Okay, we're ready to
Alright.
start. Okay, ready to start?
Dr. Baha.
To start. So do you share screen? Ready to is my screen ready?
Yes. No,
Yes.
you need to put the screen share.
That
You're not
clear?
on the screen share.
I think he has a problem with internet.
No, his connection is terrible.
Yeah.
Unfortunately.
Yes, I hear you. Do you hear me? Steven, how
Yes.
no?
Now it's better, but
Yeah,
sometimes
please
interrupted.
start because your picture's taking up bandwidth. Can you please start, Dr. Musin? Share the screen first. Oh boy, we're gonna have trouble. We're gonna figure out how we can do this. You know, he can present on his smartphone. I've done that before. Ahmed and Abdel, there he is. We'll try it, but maybe
I changed.
Dr. Musin, do you have a smartphone?
Yes, I have a smartphone. Do you hear me? I changed my place right now.
Because
Is that
maybe you can use that to present.
I don't know if I can
And you
share.
can send us the PowerPoint and we'll change the slides.
I
Okay?
see.
Can
Is
you
that
send them? Can you send them to Ahmed or me?
sure? So do you hear me better right now? I changed my location. Is that by any chance better right now?
Yeah, it's good now. Yeah, it's good. Okay, yeah, maybe we can try it. Go ahead. Okay. Screen
Yeah,
share, please. Let's see the screen
sure.
share.
Yes.
Okay,
Coming
make
my
it full size
screen.
again. Play, put play. Okay,
Good.
perfect.
Oh,
Okay, you're ready?
all right. So again, let me introduce myself. My name is Dr. Baha'Elddin MD. I'm a neurosurgery consultant with an expertise in brain tumors and skull-based surgery. So thank you for the invitation for this international webinar. And I would like to extend my appreciation and thanks to the Walter Dandy Society. Walter Dandy is a very famous and prestigious neurosurgeon who has a big contribution for neurosurgery in each aspect, in each subdivision of neurosurgery, from brain tumors, from CSF circulation and others. So my presentation is about skull-based tumor surgery in the context of evolution in the radiosurgery. So my current practice is like mixed between general neurosurgery and I would say brain tumor, skull-based and spinal cases. So I do most of the things, but my expertise is in the brain tumor and skull-based. So in my presentation, I have nothing to disclose. So what is the radiosurgery first? So the concept of radiosurgery, it's a minimally invasive radiation to treat lesion inside the brain. So it's without opening the skull, we give some radiation to small areas of the brain that, for example, let's say brain tumor or small vascular lesion, deep-seated, small. So we do it without the need for surgical intervention. So one of the forms of the radiosurgery is the gamma knife radiosurgery, which is more focused beam of radiation for brain lesions. So the variety of lesions that can be treated with gamma knife radiosurgery, from brain tumor, vascular lesion, and even for functional disorders. And it is achieved with accuracy. When we speak about brain tumors, I choose this topic because it's a very prevalent topic and we see it more frequently. Brain tumors can be classified as a benign tumors, malignant, primary, or secondary brain tumors. When we say primary, it's coming from the brain cells itself. When we say secondary, it means it comes from other parts of the body and go to the brain, like, for example, breast, from the lung, from the GI, from the kidney, and other places. I will take one of these brain tumors. The brain tumors are wide range of brain tumors that we deal with on a daily basis or on I would say monthly basis at least. One of the most frequent benign lesion is the meningioma. That sometimes it's considered the most common primary brain tumor. Meningioma can be classified either in the skull base or non-skull base meningiomas. What do we mean by the skull base? What is the skull base? In a very simple definition for the skull base, it's the area that separates our brains from the face and facial structure and from the neck. So this is the skull base. So it's the area between the brain and the face and the structures inside the neck as well. And the skull base, it's divided into three places, three segments. It's either it's anterior skull base, middle skull base, and posterior skull base. So different locations, different bone structure that form the skull base. So now we will shift our lecture to speak about the brain tumor that arises from the skull base. So in our definition, there is no routine skull base or no routine brain tumor. Every case or every brain tumor has his, I would say, a specific characteristic. So for example, if you see in this picture, this is the first image showing a recurrent meningioma crossing the midline, compressing the chiasm, and the patient has 2 previous surgery. And the other picture is showing massive, large anterior skull base tumor with eroding the bone and extending outside the forehead. Some historical perspective about brain tumor surgery. So alongside Walter Dandy, there is Harvey Cushing as well. He is a renowned neurosurgeon with expertise in brain tumors. And this is one of the places that I visit and had some training or some, I would say, some experience in this institution, big institution in the United States that has some reputation, either on the clinical side or on the research side. I would like to speak about like some historical perspective about the craniotomy. I always try to speak about history in my presentation. And one of these historical points that I need to mention is the first time that the craniotomy was done. It was done by Abu al-Qasim al-Zahrawi. Apocalypse is known in the literature is Apocalypse. And he did the first craniotomy, like as I would say, probably like 3,000 or 4,000 years ago. One of the, I would say, one of the earliest neurosurgery practice in the Middle East region, or one of the first neurosurgeon in the region was Dr. Anton Tarazi. He is the first neurosurgeon to cover Jordan and Palestine in the 1950s. And on his small footsteps, Dr. Isaac Maraka continue his legacy of neurosurgery in the region of the Middle East. So before we dig into the details of the skull base anatomical structure, we need to know that, as we say, we have the anterior skull base and the middle skull base. So what are the key structure in this area? So in the anterior skull base, we have the clinically relevant anatomical structure. I will not dig into the details of how many bones and how many, what is the thickness, what is the like the name of the bones, what are the prominence. It's not like anatomical pure lecture, just like the what is important from the clinical standpoint. So we have the what we call the olfactory groove. Olfactory groove is the place where the cribriform form, where the olfactory nerve come from the nose and pass through the skull base to reach to the brain through the cribriform plate. And we have what we call the plenum sphenoidale and the tuberculum sella, which has the pituitary gland behind it. And in the middle skull base, there is a different vascular and neural structure in the skull base. So we know that we have the trigeminal nerve branches, we have the cavernous carotid artery in the middle cranial base, and we have the Gasserian ganglion and the cavernous sinus. So this is some relevant anatomical from the arterial and the cranial nerve standpoint that has relation with the middle skull base. Middle skull base approaches, I'm trying to make my presentation very simple so all the audience can understand the details. So this is a demonstration for our approach for the middle skull base. So every region of the skull base has its own approaches. How do we approach this? How we reach to region inside the skull base? If we speak about the anterior cranial base, probably like 10 or more of approach that we do. Same thing for the middle cranial base, 5 or 6 known approaches, how to approach the middle cranial base. So everyone has his own experience and everyone has his school in the skull base. So this is how we do the middle skull base approach. I will not dig into the details as I know there is a lot of, I would say, probably like neurosurgery resident, or I will keep it to the end for the question. But the important for the audience to understand is the structure. Again, this is the craniotomy that we do after we removing the bone. We can start seeing the middle meningeal artery as it arises from the middle, from the external carotid artery and the internal maxillary artery. Then through foramen spinosum, the artery passes through the foramen spinosum to the middle skull base. It's very important to recognize and identify early through our approach to the middle skull base, so we can cauterize it and we can cut it. That will help us to facilitate and even get more exposure to the middle skull base. One of the key bony elements in the middle skull base is the Kawase triangle or the petrous apex. so many syndromes, like for the medical student and resident to be aware of. For example, Gardner syndrome and other syndromes related to the petrous apex when we have an infection, and the cranial neuropathy. So this is very important from the clinical standpoint to and anatomical standpoint, like not to memorize the lesions and the, I would say the syndromes, just like you can imagine it, put a real map in your brain for the anatomical, relevant anatomical and pathology that arise in this area. Once we move for the very important, this is, I would say, more complex dissection for the middle skull base, for the carotid, internal carotid artery as it enter the middle skull base. The carotid artery has a very different segment. We have the petrous carotid artery, we have the horizontal and laceram carotid artery, and we have the precavernous carotid artery. So this picture illustrate the different segment of the internal carotid artery and its relation to the skull base. So one of the most important structure to be aware when we navigate through the middle skull base is the internal carotid artery. And when we go more anterior to the cavernous sinus, we have to be aware of the branches of the cavernous carotid artery, as it's has a very important implication on the microscopic side, microscopic approaches or endoscopic approaches through the nose. Again, this is one of the paper that we publish about the branches of the intracavernous carotid artery. This is a very nice paper, illustrates the branches of the cavernous carotid artery, the cranial nerves inside the cavernous sinus, and its a blood supply. I would strongly recommend the people on the webinar to review this paper, read it, understand it for better understanding. So why we like make webinars, why we read, why we develop ourselves. So this is one of the Walter Dandy pictures in the 1970s. We are aware that Dandy was a very excellent neurosurgeon, but if you see in his book, he was swiping a tumor with his fingers out of the brain, which was very acceptable at that time. But right now we are getting less traumatic to the surrounding brain structure with more minimally invasive approaches and gentle techniques to resect tumor outside of the brain. And the second picture for a German neurosurgeon, as I think, is Fred Krause, removing the cerebellar or pineal region tumor with his finger. So at that time, this was acceptable. This was published in the books. But with time, we should shift our paradigm from classic or from the classic approaches to more advanced and minimally invasive and applying more technological advances in our approaches. So again, for any skull-based tumor or any brain tumor, there is a personalized approach. So every patient has his unique profile. Every tumor has its own characteristic. You cannot, I mean, this is not like, I would say, some other subspecialty, like medicine. You cannot standardize. You cannot say, oh, okay, we will do this for all of our patients. It's very difficult. You can put a general frame, but you cannot standardize the management or the approach for every single case. So the size of the tumor is very important thing to consider, the type of the tumor, if it's a benign or malignant. This is a very important, and like how aggressive you will resect the tumor, and as well as the relation of the tumor to nearby relevant structure. Again, the management of skull-based tumor has three main options. Either the observation, either you monitor this tumor over a period of months, or you do a surgical resection with open approach, endoscopic approach. Very important approach is the stereotactic radiosurgery approach, the gamma knife that we mentioned. I mean, many people try to resist this approach, but this is very important to understand and very important to apply in the daily practice. And there is always a multidisciplinary approach where you speak with your neuro-oncologist, with the radiation oncologist about what is the best treatment options. Again, the gamma knife, it's a minimally invasive same-day procedure. You can treat small deep lesions and has a short recovery. It consists of 198 source of radiation that hit the brain lesions at the same time. Can you imagine 198 source of radiation at the same time hit one single spot? And this is one of the important tools that we use when we deal with brain and skull-based tumor. This is an important paper about one of the important technique that we apply in the gamma knife radiosurgery, which is the fractionated gamma knife radiosurgery, in which we divide the treatment over 3 to 5 days to make sure that the patient doesn't have a radiation effect to the nearby structure when we treat lesion, for example, very close to the optic nerve. So it's very important to improve your technique. This is one of the papers that came in neurosurgical focus and reinforce the fact of applying technology, applying science when we treat our patient. So this doesn't apply again. We cannot standardize all the skull-based tumor. This is a growing clinoidal meningioma in a very elderly patient with a lot of comorbidities. So some people will say, oh, this is easy, let's do surgery for her. I would say, I know how to do surgery. I totally understand the anatomical and how to reach for that area, but I choose this is the definition of excellence. You select the proper treatment modality for the proper pathology in your patient, not for your best interest. Again, this is the paper speaking about the fractionated gamma knife radiosurgery for the skull-based tumor. Again, another application with a 10-year safety profile for another brain tumor, which is the trigeminal schwannoma. This paper came in neurosurgery showing a good local control for brain tumor for trigeminal schwannoma treated with the gamma knife radiosurgery. Does this apply again for all patients? No. Like not every single tumor can be treated with surgery. Not every single tumor should be treated with a gamma knife radiosurgery. So this is the area of conflict. This is the zone of uncertainty, and this is the zone of conflict between neurosurgeons in general. So this is one of my cases that I did. This is a planum sphenoidally meningioma with bilateral optic canal invasion and a decrease in the vision. So you can't treat with gamma knife. Why? Because you have an optic canal invasion and the patient is symptomatic from the tumor itself. So it's better to take this tumor out, not to treat with gamma knife radiosurgery. But for the other patient, gamma knife radiosurgery was more superior as a treatment modality. So different factors, different approaches when we deal with our patients. This is one of the techniques. Now I'll switch my paradigm from speaking about a radiosurgical technique to the surgical technique. So this is how I do my surgery. I do it so you drill more bone and you achieve the non-retractor or retractor-less surgery for tumor resection. It minimizes the trauma on the brain. So this is the video for the tumor. I don't know if it's gonna work. Oops, I shouldn't open it. What happened to my screen? Do you see my screen? Oops, sorry for that. So is my screen still clear to the presentation?
It's clear, but the video doesn't work.
I know, but I'm trying to skip the video.
Start the video
Just
again.
a second.
Start it again. Yeah, start screen share, start the video over
Okay.
again. Or you may have to just
Okay, let me
bypass it.
see.
Yeah. We can't see anything. It's not moving.
I'm trying to bypass it. I think it's not moving, correct? So I will
No,
just close it and return to my, let me just return to my presentation. Okay.
you might want to stop that
So
video
the
and
moment,
start it again. Stop and start again.
okay. So basically, I'm trying to skip it. When I press on the screen, it take me to the video again. So what I should do at that
Okay,
point?
just get off the Zoom and come back. Like exit the Zoom like you did
Okay.
before, accidentally, and come back.
Okay.
Yeah, and we'll wait for you.
Okay.
We're here.
All right. Let me just open the presentation again.
Yeah. Close it and
Okay.
open it again. Yes, that's right. There you go.
Okay. Just a second.
That's
Where
even
is
better than what I
Chrome?
suggested of leaving.
You see that? A second. Let me go to the Zoom. And where is leave? Stop share.
Yep, just start again.
Okay. Open. Yep. Yep. It's good now. All right. Let me share. Oh, you see me?
Not yet. You're not
Let
sharing.
me just. Yes, I'm trying to go back to Zoom now. Zoom. Sign in. Yes. So share again. And okay. So let's go
Okay, hold
back
on,
to
hold on.
play
Wait
mode.
to see if it comes on. Okay, now full screen. There you go. You're getting it. You're learning.
All
It
right.
should. It's
So
not. There you go. Perfect.
yep.
Perfect.
So is it now? Okay. Perfect. So again, this is one of the this is one of the giant tumor that I did. When I was a very junior at my I would say my start as a staff. This is a big brain tumor with herniation. So for this patient, you just need to go to the OR and take this out. You should aim for any block resection because the tumor was malignant. So this rare brain tumor came from the femur. This is an example of a metastatic brain tumor from the femur to the brain, and this is a malignant tumor you should take out aggressively. So I resect the tumor, I resect the bone. As you see, this is the image after the resection, the MRI scan on the left side. And this is the anatomical. And like if you see on the right side, you can see the bump in the forehead. This is the tumor. It was about like 7 centimeter extending out of the skull to the forehead and 7 centimeter inside. It was like a huge, massive malignant tumor that I resected previously. So this is like no radiation or no gamma knife, just a regular knife. Okay, so this is an example of a tumor where I applied both surgical resection and the stereotactic radiosurgery. So we say that some tumor can be treated with gamma knife and some other tumor need a surgical resection. At some point, some tumors need both. So you resect, you give the gamma knife or the stereotactic radiosurgery. All right. So it can be on both sides. And this is the concept. Like some skull-based surgeon will argue, oh, you should stay for another 4 or 5 hours to resect the tumor completely. I can do that. This will increase the morbidity and the mortality for the patient. And I am aware that the radiation going to help the patient on the long term. So why I need to spend an extra hour taking the patient for more risk and more complication? So take what you save can take. This is not an explanation to do less, but sorry, this is not a justification to do less, but always remember that you have an important tool that can help you to get a significant I would say, surgical goals. This is one of the tumors that I did. It was a recurrent case. I did a third surgery. So recurrent surgery are always very challenging and very difficult. So this is, if you can see after opening the cranium, this is the bone flap. It was totally destroyed bone flap, and I managed to resect the patient, resect the tumor safely, and the patient went home in a very good condition. One last thing to mention about the pituitary adenoma. This is an example of a pituitary adenoma, a common benign tumor in the skull base. And this tumor has enormous revolution in the technique that has been used for treatment of pituitary adenoma. It was treated previously transcranially. It was has microscopic, and technique is the endoscopic technique with the technique that this is me and my ENT colleague resecting this tumor. So the ENT colleague do the approach for me. I do the cellular part and the tumor section part, and he will do the reconstruction for me. This is a new minimally invasive approach, achieve very excellent result from the resection standpoint. One last thing to mention is the tubular resection. If you can see this is a massive hematoma in the brain CT scan, and I applied a tube inside the brain to suck all the hematoma from the brain without the need to make a big cortical incision for the patient. All right, and this is one of the new MIS technique for brain surgery. This is one of the other surgical cases that I did. Again, what are the key to happiness? You are in the phase of learning nowadays, correct? So always remember that mastery to improve your skill and excellence is very important to achieve deep sense of satisfaction. Always, the autonomy is always linked, comes with the feeling of freedom, allowing you to, it helps you to achieve your goals, and you should always have lack of economic hazards. You should have a good financial support that will help you to achieve your goals. And always remember, you are in a training right now, but one day you will be in my place speaking to other people. So you should share your knowledge, you should share your skill, and you should teach other people. So right now I'm speaking, I'm lecturing you, but put it a goal that, okay, I'm in 15 years, in 10 years, I'll be the person who's lecturing the other people, and you will achieve this goal. Okay. Thank you so much again for your invitation. I tried to simplify my lecture and the way that I speak so everyone can understand it. If you have any question, please let me know. I'm happy to answer all the questions.
اوكي ثانك يو دكتور بهاء الدين محسن ل ل ل ل
You can speak.
presentation
You can.
wonderful.
I'm not hearing well.
We are happy to connect with you.
Sure, anytime. You can speak in Arabic. I totally I can speak and understand Arabic well. So إذا حابين تحكوا أي شيء بالعربي أنا جاهز. I'm ready to speak.
جاهز. شو اسمه انت من الاردن وانا من فلسطين والدكتور احمد من اليمن وجون فلفل.
حياكم الله، أهلا وسهلا. إن شاء الله بنزوركم وبنشتغل، بتتدربوا تحت إيدي يوما ما، أو بنشتغل مع بعض لما تكونوا أنتم في عياداتكم إن شاء الله، في عملياتكم أول ما تكونوا تمام.
ان شاء الله.
First of first of all, I'm so appreciated and thankful for your great presentation. And I mean, secondly, I want to just ask your sense if there is a residency opportunity with you in Jordan or another country.
Private practice, and I am new here in my new working place. Probably in
Mm,
the future, I might have an affiliation with a training place that I can, I would say, teach resident. Right now,
mm,
in a private practice, you are like more cautious, you are more obsessed with your cases and your
mm,
results. I would say in the governmental sector, or I would say university place, the case volume is high, and I would say the exposure will be high for the trainees. So it's a better way. I trained so many residents and I would say colleagues and other people. Like I love to teach, learn, and give. But currently, I'm not working I would say, in a training place. In the future, if I had the chance, you are welcome to observe my surgical cases, and probably if I joined I would say university or a public hospital, you're welcome to help and to learn with me. All right.
mhm,
Yeah, thank you, doctor. We had Dr. Sabea. He did Jordan neurosurgery grand rounds for a few years with us. And I'm sure
Nice.
you know Dr. Sabea. He loves to teach also. So
Sure.
we'll be in touch
For sure. I'm
from
happy.
Neurosurgical TV. We'll be in
And
touch.
I would say your dedication for neurosurgery, on the webinars, is very amazing and inspiring for the young.
Yeah,
I would say,
we hope to get better. We hope to
sure,
get
you
better.
are you are good. You are good, and we will keep on touch. And
Okay.
I'm planning to visit Miami at some point. Just my schedule is full, but Miami is a place that
Sure, just let me know. Let me
uh,
know.
you call them the snowbirds, right?
Okay,
The
yeah,
snowbirds, yeah, right?
that's it. Yeah, there we go.
All right.
Okay, Abdel, you want to sign off? You want to finish the program, please? Abdel,
نعم.
could you explain, Ahmed? We're
Well,
gonna,
I don't know if there is anyone want to ask anything about this lecture.
yeah, okay.
There is
No, no.
Is there any questions there? I see
there
one
is a
there.
question.
Yeah,
There
go
is a
ahead.
question, by the way.
Go ahead. Read it,
Just a
please.
minute. Yeah, yeah. Just a minute. Uh, the colleague Mariam asked it. I know it is not exactly related to our topic, but I was wondering if you have any thoughts or recent discussion about radiosurgery for epidermoid tumors and its outcomes.
This is a very hot topic. I mean, the person who's asking this question is, I would say, this is like control. So epidermoid is a benign, complete benign tumor. So this is, I would say, despite my radiosurgery background, but I would rather just like boom, go ahead, take it out. It's like easy, clean surgery most of the time. For, I would say, recurrent small pieces, radiosurgery might be used, but not as an upfront approach for this tumor. Is that clear?
The person just asked that question. We're not really interacting with them.
Yeah.
So, okay. Okay, Abdel, what do you want to do? And Ahmed?
To me, I have no more questions, but again, I would like just to thank Doctor for this presentation, and I wish it will be like a beginning for coming webinars and series of lectures in the coming few months.
Sure.
And in person, I wish I can meet him in person in the next few months. And as you know, as a marketing administrator in the WFNS conference, let me say, it's my privilege to invite Your Excellency to join us in Dubai in December this year.
I can do that. It's very close. It's a 2 hours or 3 hours flight. It's a good
Uh-huh.
place for vacation.
Oh, okay, that's amazing.
Oh,
So let's meet over there.
sure, sure. I mean, once you send me an invitation, I might plan my schedule and I can give more comprehensive talks. So is that a meeting for the Walter Dandy or something, or just a
No, it's like you can say for WFNS, World Federation of Industrial Societies. Yeah, it's just for all neurosurgeons in the world, so it's global. Yeah,
I
for
mean, you said,
WFNS Society.
yep, World Federation. If I get
Yeah.
application for presentation, I'm happy to be there. All right.
Yeah, Doc, Ahmed is doing something different. He's organizing the lectures. He's starting to organize them. It's not just one here, one there. He has a
Amazing.
series. He's starting to organize it. So that's a big plus. There's no other developing country that's doing that, to my knowledge.
Yep, yep, yep.
Thank you.
That's a
Right.
progress. That's progress.
My phone is
Thank you.
ringing. I am on call, and I have to go to see patients, and probably I have just like to leave right now. Like the ICU is calling me. Probably a surgical case is pending on. All right.
Okay,
Thank
Doc,
you so
thank
much
you. Thanks
for
for your
your
Good
time.
time.
luck, Doctor.
Thanks, everybody.
Thank you so much. Take care, everyone. Bye bye.